Kimberly Rengel. She is assistant professor in anesthesiology and critical care medicine at Vanderbilt University in Nashville, Tennessee. She completed her Doctor of Medicine at the University of Texas Medical School. She then completed residency in anesthesiology at Vanderbilt University. During her residency, she received the Benjamin H. Robbins Scholar Award, which is a comprehensive mentored research program for early stage physician scientists. Her research interests include frailty, functional outcomes in the aging population after major surgery or critical illness, and preventative measures to lessen functional decline. We look forward to her talk.
Good morning. My name is Kimberly Rengel, and I'm an assistant professor at Vanderbilt University Medical Center. And I'm excited to have the opportunity today to talk with you a little bit about non-pharmacological interventions that we can use to prevent delirium in postoperative patients. I'm currently funded by the Vanderbilt Center for Musculoskeletal Research, as well as the Vanderbilt Faculty Research Scholars Program, and I have no conflicts of interest to disclose. So I'd like to start by just reviewing a little bit about delirium. And delirium is really a state of acute brain dysfunction. And I like to think of it in terms of all of the other organ dysfunctions that we encounter in the perioperative period. So we try to prevent acute kidney injury and acute lung injury. And really, delirium is the manifestation of an acute brain injury, or the brain's way of saying, I'm under stress and something isn't quite right. And there are a few hallmark features of delirium that fit into that diagnosis. The first is that it's a fluctuating mental status. It is not the patient's baseline. It's also hallmarked by inattention, and then patients will either experience altered levels of consciousness, so they'll be very agitated or perhaps even combative, or they might be quite lethargic, or they will have disorganized thinking. And looking more at those levels of arousal and the psychomotor differences in the way delirium can present, there is hyperactive delirium, which is really quite easily recognizable, where the patient is very restless, agitated, pulling at their leads, pulling at their lines, trying to get out of bed. And then there's hypoactive delirium, where patients are more drowsy and inactive or lethargic. Their speech is either decreased or slowed. Perhaps they are not really aware of their surroundings. And unfortunately, especially in the perioperative period, that can be very difficult to differentiate from being sleepy because of opioid pain medications or from emergence from anesthesia. And so having a good method of recognizing and addressing delirium is extremely important. And postoperative delirium can be quite common depending on your population. So it ranges from about 12 to 13% in your general surgery and otolaryngology patients, working upwards towards 30 to 50% in your aortic surgery patients, 30 to 50% in both cardiac and abdominal surgery patients, and 35 to 65% of hip fracture repair patients. And part of the contributing factor to the hip fracture population is that delirium is well known to increase with increasing age, and folks that fracture their hip tend to be a little bit older. And why is this important to us? Well, our normal course of pathway is that we would really like patients to come in, have an operation, recover, get better, and go home. But when you add delirium into that mix, you risk patients being discharged to an institution other than home, perhaps a nursing home or a skilled nursing facility. You also risk patients bouncing back to the hospital. They have a higher rate of readmission, and they are at risk for sort of longer term difficulties with things like managing their medications, managing their finances, and other disruptions to their basic activities of daily living, and the activities that they need to complete in order to maintain independence. So delirium can really disrupt the course of a patient's recovery in a big way and for a long time. And we also know that it's associated with higher mortality in the months after surgery. So what can we do to prevent and manage delirium in our surgery patients? The very first and most important step is education and recognition. In fact, the American Geriatric Society expert panel on postoperative delirium in older adults states that all healthcare systems and hospitals should really implement formal education programs with ongoing maintenance of the refresher sessions for all of their healthcare professionals. And this is critical so that as we see turnover within the system, or as people maybe lose touch of familiarity with delirium, that they're able to recognize it, and then to recognize that they need to employ prevention strategies and know what those strategies are. And there's actually a pretty extensive format from the American Geriatric Society that ranges from starting with 1 hour to even half-day initial sessions, and then refresher sessions. Case studies, live videos, or small group discussions are recommended. Essentially, that people have the opportunity to experience or to see delirium, or an example of delirium in real life, and think about how they would manage it and how they would recognize it. They also recommend having pocket cards or tip sheets available, having leadership support this time for education, having unit-specific education that comes to the learner, and then having unit champions and peer support. So there's a multi-step process involved. And why does this matter? Because delirium may actually be very difficult to detect, as we discussed earlier, particularly that hypoactive version of delirium. And there are a couple of studies that have shown that when nurses' baseline assessments of just asking them whether or not they thought a patient was delirious were compared to researchers using a validated delirium assessment method, the nurses only detected delirium in 19% of the encounters and 31% of the patients who were diagnosed with delirium. And similarly in the ICU, when a trained research personnel used a validated screening tool for delirium and then compared that to doctors and nurses, doctors only recognized about 28% of cases of delirium, and the nurses did slightly better at 35%. But our ability to recognize delirium at face value without using a screening tool is pretty low. Plus, then we need to add in these intervention steps afterwards. So just a couple of tools that people can use that highlight assessment of all of these individual components of delirium, like the change in mental status and inattention, and then the altered level of consciousness or disorganized thinking. This is the CAM ICU tool. But there's also the confusion assessment method, which is not for the ICU. This one was specifically developed for patients who may be intubated or unable to verbally communicate. There's just as another example, there are multiple validated screening tools. This is the new desk, which is specifically for nursing, and it has at each shift, nurses document a patient's behaviors and whether or not they're oriented, having inappropriate behavior, unable to communicate, having illusions or hallucinations, and whether they have that slowed psychomotor activity. There are multiple screening tools that your institution might use, but the important thing is to use one of these validated tools so that you are able to accurately assess for delirium and to implement daily or even every shift assessments of delirium. So once we've identified which patients are at highest risk or which patients actually have delirium, what are some of the things that we can do that aren't medications to help them? And the American Geriatric Society, again, offers a number of non-pharmacological interventions, including early mobility of patients, or getting them involved in physical therapy and getting them out of bed and exercising as soon as possible, reorienting them, using therapeutic activities and cognitive stimulation, maintaining adequate nutrition and hydration, sleep enhancement, vision and hearing adaptation, making sure to restore patients' glasses and hearing aids, using nursing education and interventions, and potentially even a geriatric consultation. And this is similarly supported by the American Society for Enhanced Recovery, who recommend the use of multi-component non-pharmacologic interventions for the prevention of postoperative delirium in older high-risk patients. So as indicated here, you will mostly see these non-pharmacologic interventions come in a bundle, a multi-component bundle that addresses all of these different areas that were previously outlined. And this concept was really brought to light by Dr. Sharon Inouye in 1999, or in the early 2000s. She and her team developed a program where they identified multiple risk factors for older adults developing delirium while they were in the hospital. And then they created an intervention that went with each of these individual risk factors. And so if a patient had, for instance, baseline cognitive impairment that put them at risk for developing delirium, then they were prescribed an orientation protocol, cognitive therapeutic activities, and they would conduct these activities while they were in the hospital. They also addressed sleep, immobility, vision impairment, hearing impairment, and dehydration. So all of these common risk factors. And this original bundle, the Hospital Elder Life Program, was fairly successful in reducing rates of delirium in older adults who were admitted to the hospital, and has since been adapted to the surgical situation. So you can see here, this original bundle was employed, and there was a significant decrease in developing delirium in the first place. This is the usual care bundle versus the intervention. There were fewer days of total days of delirium within the intervention patients, fewer episodes of delirium as well. So looking specifically at how some of these bundles have been used in surgical patients, shortly after the Hospital Elder Life Program came out, there was a bundle created to reduce delirium after hip fracture because it was such a high-risk population. And this was trialed in patients over the age of 65 at a tertiary medical center who were admitted for emergent repair of a fractured hip. And they were randomized either to a proactive geriatrics consultation versus usual care, and then assessed daily with the confusion assessment method. And this geriatrics consultation addressed 10 different areas and had multiple recommendations under each area. So a geriatrician essentially was assessing these patients for their risk factors and then offering recommendations to the team. They ended up offering about 10 recommendations per patient in the intervention group. And there was a significant reduction in the incidence of delirium at 32% in the intervention group versus 50% of the usual care group. That is a little bit more resource intensive. And so they also, in a different study, created a modified Hospital Elder Life Program to help patients undergoing abdominal surgery, and tested this in 377 patients, older adults, who all received the same preoperative care and standardized surgical care, and then may go to the ICU if needed. And then once they were transferred to the ward, were cluster randomized to either usual care or this modified Hospital Elder Life Program based on which room and which part of the ward they ended up on. And then everyone was assessed daily with the CAM ICU. And this modified Hospital Elder Life Program used three components. They provided orienting communication or orientation and engaged conversation with the patients daily, provided oral and nutritional assistance with brushing teeth, oral facial exercises, post-op dietary education, as well as early mobilization. And you can see here on this graph that over time in the postoperative period, the cumulative incidence of delirium here on the y-axis was much lower in this modified Hospital Elder Life Program intervention group than it was in the control group. So that offers a promising look at potential intervention that is much more scaled down, but really targets some of the needs of specific surgery patients. And then overall, looking in a meta-analysis, the prevention of delirium in patients for planned elective surgery, you can see that there were multiple studies here where the left-hand side of the graph favors use of a multi-component bundle, improving outcomes in delirium, and the right side of the graph does not. And overall, in a meta-analysis, though it wasn't statistically significant, there was a trend towards multi-component bundles lessening the burden of postoperative delirium. There are certainly challenges to implementing these bundles. There's a high variability in the bundles, which probably explains part of the variation you saw in that meta-analysis. And there's no single multi-component intervention that is uniformly or widely supported across the literature in multiple populations. As you saw, oftentimes the bundles are in ICU patients specifically, or in hip fracture patients, or in abdominal surgery patients. And so much work is still needed in finding bundles that apply either across populations or in recognizing that different populations will require different components. These may be resource intensive, as we saw, involving geriatrics consults and multiple team members. And so it will be useful for us to identify the highest risk populations and to use those resources in reducing delirium in those populations. So I hope that you've had a chance to examine a couple of the non-pharmacological interventions available. And I encourage you to visit our website. This is the ICU Delirium Research Team, which became the Critical Illness, Brain Dysfunction, and Survivorship Center that I work in here at Vanderbilt. And we've done a lot of work in both ICU delirium and perioperative delirium or postoperative delirium. And there are a lot of resources on this website for screening for delirium, as well as many of the different interventions available. So I thank you so much for your time.